Hi, I'm Dr. Mia Duncan, and welcome to the Vaginal Channel. Here at VTV, we are your resource for all things pelvic health related. Today, I'm lucky to welcome Dr. Lexi Meister. She is a physical therapist for women's pelvic health here in the local Columbus area. We have shared patients for a couple of years, but lately we've been working together a little bit more because we share a similar story where we transitioned out of hospital healthcare system to private practice. And so, welcome, Lexi.
You?
I'd like to hear a little bit about your story and what brought you to out of network self employed pelvic PT work.
Yeah. So it all starts years ago when I was just figuring out my career. Wasn't sure what direction I wanted to take in physical therapy. I ended up in the pelvic health world, which was a really awesome set of circumstances that got me there. I never thought being a vagina physical therapist is what I would end up doing, but luckily that's the path that was for me. So when I moved back to Columbus after grad school, I worked in several different clinics and ended up in a hospital system, which was a wonderful system. We had a ton of great resources. There was a lot of community, a lot of engagement with growing pelvic health. And then things changed. And over time, insurance companies weren't reimbursing the same. I found a lot of burden on a lot of my patients, especially those who had high deductible insurance plans, that the cost of hospital based physical therapy was just becoming overwhelming. There are still certainly great hospital physical therapy programs, but I was realizing that it just wasn't allowing me to see the future as a PT the way that I wanted to. So I made the jump to work privately, which gives me full control over what my patients are charged. There's full transparency, and it allows me to work more in depthly to what their needs are versus trying to work in what the insurance company will cover. Some insurances require a reevaluation after just a few visits. And if you're not making progress, they won't reimburse care or you can't get more visits. And it felt like a lot of sessions were really tied around getting that reimbursement and getting things approved. Where now that I work independently, we can set those rules with ourselves. So, with myself and my patient, we talk through what are our goals, what are our needs, what are we capable of doing, and making that plan of care together so that they can get a comprehensive exam, a comprehensive treatment plan. They know what they're going to be paying up front. And ultimately, we see patients in fewer visits because we have more time and higher quality of care. So it was a hard transition to
Amen,
make, but
Lexi.
we get to do so much more with this different care model.
Music to my ears.
Yeah.
It's like you just played a symphony right there. And that's because one of my taglines when I talk to people about what I'm
Mhm.
doing is I leverage longer consult visits to get
Yeah.
more efficient care.
Yeah.
So you can go to another doctor for 3, 4 visits, paying,
Mhm.
ever increasing copays,
Mhm.
or do that one longer visit with me,
Yeah.
maybe one follow up. I
Mhm.
obviously am a different kind of practitioner, but I believe that we are brushing through women's health care right now. And I think a lot of women aren't even aware that it's happening to them. I was lucky enough to have physical therapists work for me
Mhm.
in a private practice model when I first started out. And we had 3 at one point,
Oh,
and
wow.
we got
Yeah.
really close. And I can't imagine being a urogynecologist
Mhm.
without pelvic physical therapy.
Mhm.
We did take insurance
Mhm.
back then, and it was a 45-minute visit for PT to meet insurance standards and be
Mhm.
able to do the exam. But I always thought it was curious how pelvic PT, we're taking a finger and inserting it
Mhm.
into a woman's vagina, or if it's a male, their anus,
Mhm.
to palpate their pelvic floor. How is that 45 minutes?
Hey, nice to
So
meet you.
yeah, and
Like,
it's
we
talk
gotta,
about like the urology handshake.
oh my gosh, you gotta build that rapport and you have to get, once you can get a fuller understanding of their healthcare journey and a full medical history or review, you can get a deeper knowing of what you're going into versus
Yeah,
meeting someone and thinking, I got to do this exam right now and not having time to dive into all that other
yeah.
stuff, which arguably is probably more important than that single, internal exam.
Well, and you talked about being on someone else's timeline, and you mentioned the insurance, but it's
Mhm.
also the hospital healthcare systems because they want you to
Mhm.
see a certain amount of
Yeah.
patients a day.
Yeah.
And I think that works for some specialties, but
Mhm.
I found it really hard as a
Yeah.
urogynecologist to see someone with, say, pelvic pain or the multitude of problems that women put off. And
Yeah.
they're sitting in front of you, and you're like, I have 8 diagnosis codes
Mhm.
I'm working through,
Mhm.
and be like, oh, hey, I have 4 more people I need to
Yeah.
see within this hour. So we're definitely kindred spirits on that. And I'm glad to know you and be working in that space out of network and raising awareness about that. Now, I want you to talk to me a little bit about what brought you into physical therapy
Mhm.
and the training involved. First,
Yeah.
specifically, certification. I There's a lot of misinformation or lack of information about pelvic physical therapy. First, that it even
Mhm.
exists, and second, well, how do I know that I'm seeing a qualified physical therapist? There's lots of people in the women's health space now. So, tell me what this certification is that tells a person, hey, this is
Mhm.
the person I want to see. They're
Mhm.
really qualified to do this. Talk to me
Mhm.
about that a little bit.
Absolutely. So, first of all, you have to have a physical therapy degree. The current degrees are doctorate degrees. There are still clinicians who have had their bachelor's or master's, but programs now are all required to be doctorate. So, you can be any level of physical therapist, again, depending on when you graduated, what your training was. But that's a physical therapist is a physical therapist, right? Depending on if you did your degree 20 years ago as a bachelor's, a master's, or a doctorate. So I do believe that even though I have my doctorate, those who graduated with their master's or bachelor's are still qualified providers. So the baseline is to
That makes
become
a
a
lot of
physical
sense.
therapist. And then after that, there's special training to become a pelvic floor physical therapist. And this is where it gets a little tricky because to call yourself a pelvic floor therapist, there is no set criteria that keeps it legitimized. So you have to do your research when you're looking to find the therapist. Now, I want to make a disclaimer before I forget. There's another degree called occupational therapy, and occupational therapists can also become pelvic floor specialists. We have tons of really wonderful OTs that also have the similar lineage. So,
And some in the Columbus
yes,
area
yeah,
as well.
absolutely. So, there's so many ways to be a skilled pelvic floor physical therapist. The first thing that we do when we graduate is we become generalists. So we can work in the general outpatient or inpatient setting. And then if you want to become a pelvic floor therapist, you have to take specialized additional courses.
Lexi, I have a question about that track to become a specialized pelvic physical therapist.
Yeah.
Is there a certification or something that someone can say, oh, I've taken
Yeah.
this type of training
Yeah.
that a person who's searching for a physical
Yeah.
therapist can see? What
Yeah.
is that?
So there's the highest level of certification, board certification, and that's called the WCS, Board Certification in Women's Health.
And has
That's
that changed in the past 10 years?
the same as it's
Same.
been. It's called the
Okay.
WCS. So those letters after someone's name, WCS, designate that they have done the highest level of certification. Now, here's where it gets a little complicated. There's two major licensing, credentialing schools of public education. There's Herman and Wallace and the American Physical Therapy Association. Both of those offer the same core postgraduate pelvic health education courses that give you the full training. So if we're working backwards, the WCS is from the APTA, and then there's something called the PRPC, and that's from Herman and Wallace.
Yeah.
So they're both really, I mean, they're very similar coursework. We have the same knowledge all in all, but the WCS is the recognized board certification. The PRPC is the same thing, but it's not recognized as the board certification because it's through a different governing body.
It totally makes sense to me. It reminds me a little bit of being a urogynecologist who's board certified like me versus a non board certified
Yeah.
urologist. And there are some board certified urologists that are not dual board certified like
Yeah.
me in urogynecology who have been doing this kind of work for years
Yeah.
and they're really good at it. So we
Yeah.
want to leave space for the people that are taking good care
Yeah.
of women and doing a really, really good
Yes.
job at it. But it's nice to
Yeah.
have that board certification. Like,
Yeah.
okay, I know this person has all of the credentials behind their name. That's what I hear you saying.
Yeah. And it's hard. Again, I don't know enough to speak about the PRPC. I know there's an exam involved, but for the WCS, we have to take the full board examination through the American Board of Physical Therapy Specialties. And so, it's comparing things that are quite similar. So if we're making it a little bit more simple to understand, the highest level is going to be the WCS and the PRPC. And in order to get there, you have to take the series of courses that make you qualified to obtain that degree. And each one, whether we're going through the APTA or Herman and Wallace, has a 4-course series that builds upon each other. You learn more skills through each one, and that's the basic level to get the full credential. But the hard part is when you take a weekend class, that first level, you can work as a pelvic health provider. You can be a pelvic floor therapist. And that's where it gets really tricky as a patient, because if you're going and saying, I want pelvic floor PT, and that referral sends you to the pelvic floor PT on staff, they might have just taken their first weekend course. And that's not to say they're not a skilled provider, because they could very well be, but it doesn't distinguish the additional levels required if you have your WCS or PRPC. And so again, we want more people in this field. And the way we do that is we train and we learn. There was a point in my career where I was treating patients after just taking that first weekend course. How it goes, it's how we learn. It takes several years to accumulate the treatment hours needed to be able to progress.
I think what's important though is the beginning physical therapists I've worked with before will be really forthright about that.
Absolutely.
And they will be the first to tell you. I think I get a little bit more concerned about the people that do the weekend class and aren't really forthright about that, because those are people that may be in over their head. And I think this is an area where it's really important as a patient who's searching for pelvic PT to really know and learn a little bit about these certifications. I know this isn't the most exciting part of what we're going to talk about today. We're diving into the nitty gritty of the certifications, but it's important. This is where I see things go wrong. So if you are listening to this today and you're on a pelvic health care journey, you want to know the person that you're seeing and getting these pelvic floor exams with and putting in that time weekly. I've had patients as intensive as twice a week, and circle back to the doctor who may not know the PT's credentials either to find out it's not working. And so I think as much as this isn't the most sparkly part of things we could talk about, it is the cornerstone of why PT doesn't work. PT works, and I'm a huge believer in it. As a surgeon, I'm a huge believer in PT. But when it fails, you have to roll back.
It really PT that failed, or was your treatment plan just not appropriate based on the knowledge of your provider?
1,000%. So I wanted to start out with that. And before we go on some more sparkly topics, I want to talk about some red flags, or conversely, things that might make a person know, oh, this PT knows what they're doing. And here are the ones I have, and I want to see how they stack up against yours. The first is going to be that they do an exam. They use a gloved finger and they do an exam and feel your pelvic muscles. I'm not aware of any physical therapy where a treatment plan is prescribed for a shoulder or a back if those muscles have not been examined. So that's the first thing. Even if it's Kegels, if they haven't felt your pelvic muscles, that would be my first red flag. The second is not talking to you about breathing and the role of the respiratory diaphragm,
meaning that you need both of those things to occur, or
that they work together, that there's work required on your diaphragm to make sure that the pelvic floor is working. I think that's a sign that you're dealing with somebody with the appropriate level of training. And thirdly, I would say if the physical therapist is only prescribing Kegels and they're not working on overly tightened pelvic floor muscles, that's the other pain point that I see. What do you think of that list? And would you add to it? Do you disagree with any of that?
So I agree. I think that if you're seeing a pelvic provider, I think they need to have the training and awareness on how to do an internal exam. I know there's plenty of really wonderful providers out there who don't do internal exams and they still get great patient results. But if you're dealing with something chronic and complex, you want your provider to be able to do the internal exam. I do internal exams on most of my patients, but I don't make it mandatory. So as much as I want all of that information, I also recognize that some of my patients coming in are not in the mental capacity to be able to tolerate an internal exam. And so, yes, I agree that that is something that your provider needs to be able to do. But from a physical therapist perspective, if you're going in and they're saying, I have to do this on day one, that would actually be a red flag for me. So I agree. I also disagree, because that patient rapport and that patient trust is going to get you so much more than if I mandate doing that internal exam. So sometimes I don't do one on the first visit because I want to explore all of the other factors, including breathing. It could be a relational component. And when it's ready and it's time, we'll do that pelvic floor exam internally.
So I 100% agree. I deal with a lot of pelvic floor trauma, if you will, from patients who see me who have had OBGYN providers or other pelvic exam providers literally shoving a speculum inside their vagina. So I have the utmost respect for that. To clarify, I meant therapists that are sort of carte blanche, not doing pelvic exams.
Absolutely. If your provider has never done one and they're a pelvic health provider, but they're not trained to look internally, I don't believe that they're going to have the knowledge on how to treat. So yes.
I think like with my patients who are really nervous about a pelvic exam, I'm like you. I'd rather see them and have no pelvic exam than not. But I'm always trying to work towards at least one minimal pelvic exam
so
when
you
they
can get the understanding.
feel ready. And depending on what I'm doing or prescribing, there may be more loopholes there, but I couldn't agree with you more. So in terms of the red flags, anything else that you can think of?
If they're not doing a holistic exam, right? The pelvic floor doesn't operate independently. It operates with how the hips are moving, how the diaphragm's moving. The diaphragm is the top of the core, deep abdominal wall. And then also looking at all those other lifestyle factors, right? We have our foundation of sleep and nutrition and hormones, and looking at how the rest of the body is functioning, we're probably missing the big picture. And so if your therapist just comes in and says, hey, tell me about your pelvic floor, let's do a pelvic exam and let's move on, I would be concerned, because again, there are so many things that interplay with how that pelvic floor is functioning. And then I could be on a soapbox all day about Kegels, because I truly believe that there is just such a tiny part of the population that actually has low tone, weak pelvic floors that would benefit from a prescription of Kegels in their physical therapy journey.
Well, tell that to Dr. Kegel, who ruined all of our lives.
I try to be grateful, because that spread the awareness. Kegels became such a common name that actually put pelvic floor therapy on the map, right?
Yeah.
At least when people come into my door, they're like, oh, Kegels, there's some familiarity with the topic. So thankful for that, but gosh, let's throw them out.
I 100% agree. I mean, the whole history of Dr. Kegel is a whole different discussion, but I feel like the Kegel issue is a double-edged sword. I'll be the other side of the sword just for funsies. The problem is it's so in people's head about Kegels that it's tough to move past it. And when you tell people that their pelvic floor muscles can be overly tight and not relaxing, that we need relaxation and trigger point release, they literally look at me like I'm crazy. And I have to, as a practitioner, sort of almost, I want to say, beg to get them to go to pelvic physical therapy and see you.
Many of them just think, oh, I can do my Kegels at home. I don't need to go to a pelvic floor therapist.
Well, before we dive in, maybe we should quick sidebar over to why that happens. And I'm going to blame us first in the MD side of things. And that's because we've given out PT handouts for years. And I mean, I think people would be really angry if they had a hip replacement and they're just given a handout of exercises from their orthopedic surgeon. But the bar is so low in women's health that we're like, oh, sure, I just got a handout, or I was told to go figure out on my own how to work muscles that control sexual function, bowel function, and urinary function. I would argue that if, other than the respiratory diaphragm, that's a really important muscle group. So I feel like we contributed to that. Do you think the PT world did? Because I know there's orthopedic PTs that prescribe that have not done a vaginal exam and don't ever intend to, that prescribe Kegels. Tell me about your transgressions.
Absolutely. I mean, I learned about the Kegel.
Not yours, your colleagues.
As a general, as physical therapists.
You're perfect.
Right. As physical therapists, we learn basic treatments as we're learning in school and as we're graduating, and Kegels was part of it, because we learn about the complexity of the core and how the pelvic floor is part of it. And so naturally, oh yeah, if we're strengthening the core, let's strengthen the pelvic floor. And oftentimes the awareness stopped there. So we thought, if we have to strengthen the core, let's add in a pelvic floor contraction. That makes sense from a superficial level. And that got carried on. And then as myself personally and pelvic health therapists have done more research, have had more patient cases, have really started to look at more of the complexities of how the core works. There's this big aha moment of it is not just about tightening a muscle. A muscle has to move through a lengthened motion to be able to contract. Whenever I'm doing a pelvic exam on my patient, there's so much more at play, but I essentially say we're going to find one of three scenarios. We're going to find that your pelvic floor is truly too weak and it can't contract. We're going to find that your pelvic floor is stiff and it can't move, we're limited due to its passive.
It's like a Charlie horse with a pelvic floor and it can't let go.
Move. Or it's somewhere in between where it's both stiff and weak. In 2 out of those 3 scenarios, we have to address the tension first. You cannot strengthen a muscle until it can move fully if you want the best result. So for most scenarios, we're going to have to let that muscle move before we rebuild strength. So yeah, I do think physical therapists are part of the problem too, just because again, you're thinking, oh, we got to create strength in the core. Let's just tighten up that pelvic floor without really conceptualizing how that muscle needs to work, right?
So I've had patients come to me that have an overly tight pelvic floor, which we both agree is the more common variation, not so much the loose or lax pelvic floor. And they'll say, oh, well, the physical therapist saw me and they said my muscles are really strong. And I'm like, oh, I don't know. Are they? Because a tight muscle isn't really a strong muscle.
Exactly.
And
it might feel like there's a lot of compression, but if the muscle cannot develop power from that full relaxation phase first, it's not actually functionally strong.
Here's a term I use with my patients, and I'll fess it up. You can tell me it's a good one or it's a bad one, but I use the term excursion. And I see it's really important for your respiratory diaphragm to be able to move up and down versus be fixed in a certain spot. And you said getting it moving again. And I think about it like the word excursion.
I love that.
And how we would think about it at the gym for people out there that work out and things like that is range of motion.
Yep.
Right? But we just can't see it. We're just like sitting on it right now with it quietly slaving away for us.
Yeah.
Enter our little friend.
Our pelvic model.
Why don't you walk us through these pelvic floor muscles? And let's start with the superficial pelvic muscles, because I think they are just real jerks when it comes to women's pelvic health. Why don't you take us on a little journey through the pelvic floor here, starting with the more superficial pelvic muscles. Hold on one second.
Yes.
I have to get Mrs. V here. And I want to just say that if we were to superimpose this vulva on the outside, the skin that touches your jeans and your underwear, this is what is right outside of this area here, just for a visual.
Right. So we have our superficial external tissues out here, and we take that away, and then we see the muscular layer. So just to orient, when we're looking at the pelvis, we have our pubic bone in the front, the tail in the back, and then we have our 2 sitting bones. And within that area, we have that group of muscles, the pelvic floor. Those muscles sit underneath, kind of like a little hammock. And those hammock of muscles function for bowel and bladder control. They support sexual and reproductive function. They're a support system for our internal organs, our bladder, our uterus, our rectum. And then they're also a stability muscle. They're part of the core. So when we talk about the core, right, pelvic floor is the bottom. We have our breathing diaphragm, our deep abdominal wall. So it's this canister of muscles. So the pelvic floor has a pretty huge responsibility. If we look at the outside, we have superficial muscles that wrap around the vaginal opening up towards the clitoris. If we take this layer away, we have a second layer, the deep transverse perineum. And then if we look internally, we have the deepest layer of muscles that attach up into the pelvic wall. Some of our hip muscles are intertwined with those as well. So it's this really deep, intricate network of muscles that support up underneath, and they work to help open and close, as well as provide that lift up and down for support.
What I see in the superficial pelvic floor, which is these muscles out here, is a lot of sex pain, a lot of painful orgasms, pain with sitting.
Yeah.
What are some other things you see, and how do you know you're one of these people if you're watching this and you're like, wait a minute, I didn't know that was my muscles? Tell me about that a little bit.
So if we're looking just at the superficial muscles, a lot of the vulvodynia, right? A lot of the burning pain, the pain with any touching of underwear, or if the leggings are rubbing, things just feel like it's burning. So many patients come, they're like, I have a UTI. And they've gone through the diagnostic criteria for that, but sometimes we'll find it's trigger points in these muscles. or it's tension or dysfunction of those muscles. So when we talk about the term trigger point, most people are familiar. Oh, they get a knot in their neck and it gets, it's a little lumpy and it hurts. The pain can be so variable, right? Someone might say it's a deep ache. Someone else might feel a burn. Someone else might get a headache behind their eye. But intuitively, if it's tight, you might rub it, you might stretch it, right? Our pelvic floor doesn't give us the same intuitive signal. Our sensory systems are different. I give this example for women who can wear tampons with ease. Typically, when you put the tampon in, you don't feel it, right? Once it's in there, we don't have the same sensory organization. And so a trigger point in the pelvic floor doesn't intuitively feel like, oh, this is coming from my muscle. It's a trigger point.
Especially if it feels like burning.
Exactly.
And it's vaginal pain or urinary tract pain. And I find it's hard over the years that I've taken care of people with pelvic floor issues for people to name where it's coming from. It's here, it's there. And sometimes they give these histories that are a little bit more wandering because they themselves don't know how to name it.
Yeah.
And it confuses doctors that aren't in the know, which furthers the problem. But it's a hard place to articulate what you're feeling.
And if we think of the muscle that wraps around the outside, the bulbocavernosus, it attaches right up at where the clitoral hood is. And so clitoral pain and pain with orgasm or challenges with orgasm and changes in ability to climax can have a relationship with how these muscles are functioning.
So you know that I can't stand ageism in pelvic health because everybody has a pelvic floor. And a lot of people, especially in urology part of things, you see babies born with spina bifida or myelomeningocele, and they were born with bladder issues. But I also see a lot of young girls that have started out with maybe reflux and UTIs, maybe a little bit of pee problems as a kid, maybe bedwetting into their teens, or maybe beyond where most people had stopped bedwetting, some that never stopped bedwetting, even going into adulthood, that ultimately all have pelvic floor issues. And I feel like they get left out of the conversation. So I want to talk about some of the younger people that you see, because I've seen way too many teens end up with issues and they really do suffer in silence. It's like, you can't talk about it in our culture until you've had a baby. In fact, when I was looking up photos for a video today, every time I looked up vulva anatomy, I got maybe a picture of a vagina and there was like a baby's head everywhere. It was like just trying to get some illustrations was really hard. And so if you find yourself with any trouble, especially if you're a young person that hasn't had a baby, it's like there's nowhere to go. So tell me a little bit about that population.
I mean, like you said, everybody has a pelvic floor, men and women. Pelvic floor conditions are not limited to the pregnant and postpartum. I mean, we certainly see our fair share of issues in that population, but everyone has a pelvic floor, and muscles can misbehave for a multitude of reasons any point in the lifespan. But it's a taboo subject. I think people are talking more and more about it. I think this postpartum and pregnancy movement of retraining the pelvic floor is wonderful because it's allowing more conversation. But let's not leave out those who are falling outside of those brackets because they still have pelvic floors. In young girls, and I mean, we see it in boys too, can have issues related to bladder problems, bowel problems, or pain. I can't tell you how many women I've seen because they've never been able to insert a tampon and they've been told, oh, maybe it's your hymen. Maybe your hymen hasn't been perforated yet.
Oh, I love this one. You just haven't had a baby yet. Don't even
So we
get
only
me
need to use our
started.
pelvic floors for babies? Come on.
And it's like this idea that, oh, well, once you've had a baby, you won't have a problem. But what about until then? And what if that person isn't going to? And I know that sometimes that does help with sex pain, but I've taken care of a number of teenagers that can't place a tampon, and it's really a huge impact. I took care of a young girl. Her whole family couldn't vacation normally because if she got her period and her brother was also a teenager, they're like, can't go in the pool.
It's just a huge part of your life and your psyche as you're forming as a child and a teenager. And
and when I fixed her pelvic floor along with one of my PT colleagues, her whole family thanked me. It was the cutest thing ever.
So things that might not seem like a big deal, it's such a big deal if it's your life. And especially when we talk about something so private. We could also wrap in all of the concepts of shame that we have in our culture around this part of our body. We respect that it's private, but sometimes with that narrative, it becomes so incredibly shameful. And it's hard for girls to talk about it. It's hard to articulate it. it's hard for them to talk about with themselves, their peers, their families, let alone medical providers. But I think we need to start having those conversations so that people know it's not normal to have pain down there for any reason or have bladder issues along any age. It can all be treated, but we have to start having those conversations.
One of my passions right now is generational health and not generational wealth,
Oh, I love
because
that.
that is
Yes.
only accessible to a very small portion of people. I wrote an article recently talking about what would the world look like if we passed along what we've learned about our health to our daughters. I'm of the belief that if you're between, let's just say, 30s and maybe mid 50s, that you're the hinging group of people that is responsible for trying to do better by your kid if you have one. And you may be the sort of saving grace for your parent who's in a rest home with recurrent UTIs or incontinence. And I really think that the burden of change to some extent lies on this age group. And I think it is really important that we start being like, you know what? My vagina is burning right now. I mean, I'm kind of kidding and kind of not. Everyone's okay with stress incontinence. I'm not saying it's not important, but I feel like everyone jokes. I jumped on the trampoline and I leaked a little bit. But meanwhile, behind that, there is a lot of much more serious dysfunction that we're not talking about. And I do think it's important for brave people like me to just be like, it's on fire. Just talk about it.
The conversation has been normalized now about, oh, you had a baby. Oh, you can't jump on a trampoline because you're going to pee a little bit. Hee. Like, thank goodness. Now people can say that without feeling shame. But yeah, let's come back to the other things that can happen with the pelvic floor that are still so buried underneath this cloud of taboo. We can't talk about these things.
I'm 25 and I can't have sex with my partner, but I'm young and beautiful and my friends are talking about having babies and I feel ostracized. I mean, there's just countless people still hiding in the shadows. And I swear that I'm going to do whatever I can in this life to open those doors. And if that means talking about whatever I have going on in the southern regions of my life,
talking about vaginas 24/7, we're going to do it.
Yes, absolutely. What else would you say to people? I know that we touched on younger people and we talked a little bit about men too. And what about my trans brothers and sisters? Because there's a lot of pelvic floor issues there too, which are super important. Can you talk about trans pelvic floor issues that you run across? Anything else?
I think just to acknowledge that any symptom related to bowel, bladder, or sexual function that does not feel normal to you is worth exploring with the provider. We talk about trans populations and having surgical procedures. 100% you should have a pelvic floor therapist on your team, because that's 100% a scenario where you're going to need somebody to help guide you through the changes that are happening post-surgically, the changes that are happening hormonally that could affect your quality of life.
It's not just surgery. And I've taken care of trans patients over the years, and there is definitely a lot of pelvic floor dysfunction, and surgery can worsen that actually. And spoiler alert, I hope to be interviewing somebody soon who is a wonderful gender affirming surgeon in this space. Just a little teaser there. But I really like what you're saying, that it isn't just about the surgery. It's about just taking care of that whole person. What other pearls do you have? Do you have a pelvic health secret?
I have a pelvic health secret. I feel like I'm putting it all out there.
I mean, we just gave a call to action to everyone out there to talk about whatever. What do you got? Any pelvic health secrets? Anything you want to dish on? Spill the tea, Lexi. I can spill some tea if you don't have
spill
anything.
some tea, and then I'll see what I got to spill.
Okay, so mine's not very exciting. But have you ever had a butt cramp so bad that you wake up in the middle of the night? I know you know what I'm talking about. I have levator ani spasm, which is basically these muscles here that insert around your anus. And if anyone out there is my friend, you're like, oh, we knew she was a little uptight, but before I knew what it was, I went to the doctor and was like, hey, you know, why is literally my anus at the time, I think I was a patient, waking me up in the middle of the night. And they're like, oh, you must be constipated. No, I'm not constipated. But anyhow, if those muscles start to spasm, it is extremely painful. It can wake you up out of a dead sleep. It's like a Charlie horse of your butt, all these little muscles around here. And I have had that for years.
Mhm,
So that's, I guess my dirty little secret.
That is your dirty little secret. I fortunately don't think I have any personal dirty little secrets to share.
Darn
But
it.
as soon as I do, I'm going to call you up and I'm going to come on here and we're going to
You'll make an
about it.
appointment to see me.
Yeah.
Is what will happen.
But
I do want to say I've had that butt problem.
Yeah.
Since I can remember, since I was probably a teenager. I mean, maybe 18, 19, 20. So, I mean, this is not an older person problem.
But talking about these obscure things, right? Like a literal pain in your butt that occurs randomly in the middle of the night. And then it probably is fleeting and goes away.
Yeah.
How many people are dealing with that and they think, oh, well, it went away, and they never think to talk about it. So yeah, if you're having random pain in your butt, literally in the middle of the night, it could just be a levator spasm.
Yeah.
But it all could be signs that something in your pelvic floor is not working correctly. And what does that mean down the line? I've had patients with a whole host of really odd symptoms: phantom clitoral pain, random nerve shooting pain down the legs, feelings like they've peed their pants and then they didn't pee their pants, and it's not neurologic related. It's not coming from their spinal cord. It's coming from spasms in the muscles. There's never TMI in my office. And so I have heard a little bit of everything.
I would say too, not to get decision paralysis around seeing a urogynecologist and or pelvic PT because you can't find the words. Let us help you find the words, because this is a very three-dimensional area where it's really hard to track where the symptoms are coming from. But if something doesn't feel right, if something doesn't make sense, there is no problem too small. I would say, unfortunately, in the physician side of things, we sometimes value more surgical issues in terms of how we take care of people. There are people out there like me who, and I'm not alone, I know other people that do care about pelvic health problems, no matter how seemingly small they are, and no matter how young the person is. I want to see people as young as possible. And Lexi, do you feel the same way? Like, if you have any question at all, even if it's one visit and we walk you through a few things, like, there's nothing too small. Am I right?
There's nothing too small. There's nothing too weird. There's nothing too intimate. It all is probably pertinent, and there's no matter too little and there's no matter too weird that we can't talk through. With my practice, I do free phone consults just because so many people don't want to sign up for a first visit. Sign up. We'll chat 15 minutes on the phone. You can tell me all the things you're feeling. And if it is something that we can work through and there's a clinical reason that could be behind it, let's jump in and do an evaluation.
But I'll have a link to your practice in the text below, because I want you to be able to contact Lexi if you want one of those free consults to meet and greet and get to know her. Well, I could literally talk about this all day
I know.
long.
I feel like we should scratch the surface. There's so much to dive into.
Well, that is a teaser for a part two conversation. Yeah. Any parting words for people today?
Yeah. You're not alone. If you're experiencing something intimately related to this part of your body and there's this feeling of, I don't know anyone else that's dealing with this, I don't know how to get this fixed, I've tried, I've gone to physical therapy, I've gone to doctors, I encourage you to keep advocating for yourself and to keep trying, because there are so many ways to treat dysfunction. I'll admit, there are times that I'm treating someone, I think, you know what, let's refer out to someone else, because I know that there's going to be someone else who has that specialty information more than I do. And our goal is to get you feeling better. And so if you feel like you're stuck and you feel like there's no one else to help you, keep pushing through. Don't be afraid to make that phone call. Don't be afraid to make that appointment, because there is so much that can be done when you have another set of eyes on it.
Well, I agree with Lexi. It takes a village.
Pick a team.
It really does.
If I didn't have other providers to help refer out, and not just in urogynecology, but across the board, GI,
endocrine,
sex therapists, we've got a team that we work together with to help with these issues. We all do this because we're passionate about it.
100%. So we hope that we have wrapped this into a tight, but not too tight little package for you, because I think we've learned today that
be flexible.
All things that are tight are not necessarily good. Flexibility and excursion are extremely important. Thank you for joining me and Lexi on this session of VTV. Please come back and watch more, subscribe, and hit the bell. Remember, at VTV, we are your resource and go to for all things pelvic health related.